Greetings, folks, and welcome to this afternoon's lecture that is a joint venture between the Office of Community Engagement at McCormick and McCormick Seminary's Initiative for Incarnational Ethics. The Initiative for Incarnational Ethics was started in 2017 as a project established to articulate Christian ethics grounded in social justice and embodied encounters. The central tasks of the initiative are recognizing the sovereignty of God over all of life, taking seriously the social commandments of Jesus, and practicing continual repentance. The initiative aims to help recalibrate in the church and society what it means to be human and Christian, away from harmful ideals towards healthy realities. In short, we partner with the church, local church, and social work efforts, and the academy, in an effort to recognize the task of social life together in true community, removing the obstacles that prevent our ability to be together in community, and what we would describe as healthy connections, healthy initiative, or healthy life together. The Initiative for Incarnational Ethics was established with the help of a grant through partnerships that include McCormick Seminary and the work that we are doing in ethics as a department. This afternoon, we have the distinct privilege of hearing from Dr. Carolyn E Roberts, historian of early modern medicine and science at Yale University. Dr. Roberts holds a joint appointment in the departments of history, history of science and medicine, and African American studies. She also has a secondary appointment at Yale School of Medicine in the program in the history of medicine. Dr. Roberts is currently working on a book manuscript which is under contract with Harvard University Press called To Heal and to Harm: Medicine, Knowledge, and Power in the Atlantic Slave Trade. The book traces the troubling relationship between the Atlantic slave trade and the development of modern medicine. Roberts excavates the stories of doctors, patients, apothecaries, and early pharmaceutical companies involved in this brutal form of human commerce. She vividly demonstrates how the seeds of big pharma, new power dynamics in the doctor-patient relationship, and racial bias in medical care have roots in the slave trade. Dr. Roberts is an award-winning educator who teaches undergraduate and graduate courses in the history of race, science, and medicine from the 16th to the 21st centuries. Her teaching blends history with medical sociology and public health to explore present-day crises of race and health. She's also a popular workshop leader and speaker who brings historical perspectives to issues of equity and inclusion in race, science, medicine, and public health. Her media appearances include the PBS Nova documentary, The Violence Paradox, and CNN. Dr. Roberts received an MA and PhD from Harvard University, an MA from Andover Newton Theological School, and a BA from Dartmouth College. I am also privileged to call her my friend, and my daughter's first professor in her undergraduate first year as a first-year student at Yale. We are very privileged to have you for this conversation at this very timely moment. Thank you for being with us today, Dr. Roberts.
Thank you so much. It's such a pleasure to be with you today. And I want to thank you, Reverend Dr. Reggie Williams, for the kind invitation, and also to Reverend Rhonda Hoskins for all of her help in making this talk possible. So as we begin our time together, I want to take a moment to prepare you a bit for what you will be hearing. I'm going to be sharing some difficult information with you this afternoon, and much of it never reaches a broader public. But it's time for you to be part of this conversation. We need your perspectives and insights. And for me as an educator, I believe we need to look ugly truths squarely in the face. I think it's the only way to move forward, to grow, and to heal. So I'm going to share my screen now, and we will begin. So this is our outline for today. The first part of the talk will look at evidence of racial bias in medicine today. The second part, we will look at historical legacies of medical distrust. And third, some brief reflections on the COVID vaccine. So part one, evidence of racial bias in medicine today. So what you see before you is a book that was written by Dr. Damon Tweedy. He's a medical doctor who authored this book, Black Man in a White Coat. And Dr. Tweedy tells the following story in the book. He was playing tennis and hurt his knee, so he went to the urgent care clinic. The doctor walks in the room, and the first thing he does is he refuses to make eye contact. He doesn't really talk to the doctor. And Damon Tweedy says, quote, he just looks at my leg. He has me stand up and down a couple of times and then just says, oh, you're okay. You're fine. But being a doctor, I knew there was a lot of pieces missing. For instance, the doctor didn't actually touch my knee or examine my knee. And so I made the point to the doctor that I know a little something about medicine. And the doctor was taken aback. Suddenly, it was like a light went off in his head. Suddenly, he looked at me. He made eye contact. He started to engage me in the conversation. He then examined my knee, touched my knee, moved it back and forth, and said, let's go get an x-ray. Let's make sure everything's okay. It was like I was two different people at the same time. The first person was Damon Tweedy coming off the street. He may have had certain assumptions that were negative about me. But then once he learned I was a doctor, I'm suddenly this other person, worthy of a whole different level of care. Dr. Tweedy's experience has been recounted many times in focus groups and studies of how Black patients are treated in healthcare settings. Black patients report that they're, quote, given the brush off. They report that doctors don't even make eye contact with them. They barely look at them and just start doing things. Black women have reported that they're given C-sections without the doctor explaining what he was going to do. Women have woken up and discovered that a C-section was performed. We know from studies that racial bias is a factor, and we've been studying this for decades. In a national study conducted in 2002 called Unequal Treatment by the Institutes of Medicine, they found that healthcare providers' diagnostic and treatment decisions, as well as their feelings about their patients, are influenced by patients' race or ethnicity. Studies have continued. And in 2017, reports like this started coming out in the popular press. Why racism in healthcare is still a problem today. Minorities get fewer treatment options and poor communication from doctors. We also know that stereotypes about Black people's bodies are also rampant in medicine today. For example, and this is from 2016, some medical students still think Black patients feel less pain than whites. We know that Black patients are half as likely to receive pain medication as white patients. We know that this is true when treating children as well. Or what about the crisis of Black maternal mortality? There are countless stories, but let's think for a moment about Lashonda Hazard. In January of 2019, Lashonda, a healthy 27-year-old pregnant Black woman, went to a hospital in Providence, Rhode Island. She was having a great deal of pain, but she wasn't listened to and she was sent home. When she returned home, she tweeted this: I've been having excruciating stomach pain, cramps, and they're not doing anything about it. My whole left stomach hard and in pain. I'm literally dying. And Lashonda did die. She was dead 24 hours later. Studies show that because Black women's pain is not taken seriously, this is a major contributing factor to the grim reality that Black women are 3 to 4 times more likely to die during or after delivery than white women. Racial bias in medicine is killing us. Racial bias also impacts the specific treatments that we might receive. Over the past 20 years, many differential treatment studies have been conducted where investigators standardize each patient in all aspects except race. This means that they control for confounding variables like insurance status, socioeconomic status, education, and medical condition. And this is what studies have found. Racial bias in clinical decision-making includes, for cardiac catheterization, Blacks are less likely to be referred, with Black women being offered the lowest rates of cardiovascular procedures of any group. For rectal cancer, Blacks are more likely to receive a permanent colostomy after surgery. For coronary artery surgery, Blacks are less likely to be recommended. In intensive care units, Blacks have less time with physicians. For lung cancer, Blacks are 12.7% less likely to receive early stage curative surgery. For prostate cancer, Blacks are twice as likely to undergo removal of testicles. For pneumonia, Blacks are less likely to have blood cultures taken during the first 2 days of hospitalization. For appendicitis, Black children are less likely to receive adequate pain medication. For long bone fractures, Blacks are less likely to receive adequate pain medication. For diabetes, Blacks are more likely to have a limb amputated. For heart transplants, Blacks are less likely to be referred for a transplant. The fears that we have, the distrust that we experience in healthcare settings is valid and well-placed. Our concerns and fears and our distrust are not being taken seriously in the current discussions about the vaccine. But as you can see from the evidence, we are often treated differently because of our race. Racial bias in medicine has harmed our health, and in some cases has contributed to our premature deaths. Studies conducted over the past 20 years confirm this. Long before COVID showed up in the world, this was the case. Black people who are distrustful of the medical system have been validated through these studies. Our fears have been confirmed. Now, as an historian, I work with doctors and hospitals and medical school students about what this means for them, about what their role in all of this might be. And I help put our present reality into historical perspective. Much of my work concerns the question, how did we get here? And as I often say, we can't begin to solve a problem until we know how long it has been going on. The relationship between Black people and the American healthcare system is fundamentally broken. It has always been so. It has been this way for hundreds of years. What is new and where promise and hope exists is that more people are waking up to this fact and seeking to make meaningful change. So let's now go back in time and look at just some of the historical events that have contributed to the legacy of medical distrust. Most people don't realize that when African people arrived in the Americas on slave ships, they had already had their first exposure to Western medicine, and it was a form of medicine that was brutal and violent. The Transatlantic slave trade began in 1441 lasted for 400 years. It was the largest forced oceanic migration in human history. Now, I studied the British slave trade, which trafficked most African people to the British Caribbean and the United States. So for everyone who is in the United States, most likely your ancestors arrived on a British slave ship, and multiple doctors worked on board each vessel. One of the doctor's first duties was to perform forced medical inspections prior to the voyage. Enslaved children, women, and men were stripped naked. From head to toe, every single part of their bodies was studied. Inspecting one enslaved person could last 4 hours. They were beaten, kicked, whipped, and punched if they didn't comply. Women and girls were pinned down. Their legs were held open so doctors could check to see if they had previously borne children. One observer noted that the women and girls wept uncontrollably. Thomas Clarkson was an abolitionist who gathered evidence all across the British Isles to help end the slave trade. And one carpenter described the experience of sickness on board his slave ship. The slaves in the sick berth are suffered to die in their own filth and are then thrown overboard like dogs. If they refuse the medicines that are offered them, they are beaten with a cat, their jaws forced open, and the medicines poured forcibly down their throats. James Morley testified before the British Parliament saying, "I have seen the surgeon's mates on giving them medicines, force the pannikin between their teeth and throw it over them in a manner that not one half of it has gone into the mouth. This was done when the poor wretches have been wallowing or sitting in their blood or excrements, hardly having life, and this with blows with a cat, damning them for being sulky black. I do declare that I have known the doctor's mate report a slave dead and have him thrown overboard when there has been life in him, and he has struggled in the water after being thrown overboard." African people had been utterly dehumanized. Medical violence wielded against their bodies and minds had become an acceptable, normative, and institutionalized practice in Western medicine for centuries. Upon arrival in the Americas, enslaved people were already trying to heal from the brutality they experienced by Western doctors. And throughout the Americas, enslaved people developed their own medical systems. They blended medical knowledge from Africa with new medicinal plants in the Americas. The enslaved tried as much as possible to give medical care to one another and to avoid white doctors. African and African-descended people became known for their abilities to heal. Their knowledge of plant-based remedies was widely regarded throughout the Americas, from Brazil to Massachusetts. Yet in the United States, enslaved people could not escape American doctors. During the 19th century, scientific medicine was beginning to take root in the United States. Doctors needed bodies, both alive and dead, for experimentation and dissection. There was an enormous demand, but white people's bodies were off limits. Slavery created a population of people who were forced to comply. As a result, enslaved people's bodies became instrumental to the rise of scientific medicine in the United States. Newspapers contained advertisements like this to entice slaveholders to sell their sick slaves for medical research. Wanted 50 Negroes. Any person having sick Negroes considered incurable by their respective physicians and wishing to dispose of them. Dr. Stillman will pay cash for Negroes. The highest cash price will be paid as above. This is a slave narrative written by an enslaved man named John Brown, who was subjected to painful medical experiments. Yet John Brown was not alone. A slave named Sam was pinned down into a chair by 5 physicians so that his lower jawbone could be removed without anesthesia. Dr. Walter Jones in Virginia poured boiling water on naked enslaved pneumonia patients at 4-hour intervals to test their pain threshold. Dr. John Hardin stripped blood vessels from the limbs of an enslaved man and from 3 hogs to measure the arteries for comparison. Dr. James Dugas performed experimental eye surgeries on Black subjects. Yet J. Marion Sims' experiments on enslaved women are particularly well known today. As one British surgeon noted, you could cut into the bodies of negresses like you did rabbits or dogs. J. Marion Sims did just that. He was trying to find a surgical cure for vesicovaginal fistula, where an abnormal opening forms between the bladder and the walls of the vagina, causing urine to leak out of the vagina, and it's an incredibly painful condition. Sims purchased enslaved women who were afflicted with this condition to be his research subjects. Sims operated on Anarcha, the woman pictured in the center, 30 times over a period of 5 years without anesthesia, although ether was available. He believed Black women didn't feel as much pain as white women. Over and over again, he scarified, sutured, and resutured her vagina. When the surgery was finally perfected with silver sutures rather than lead, Sims treated the white women of Montgomery and made sure to give them anesthesia. Sims remains a part of our lives today. His vaginal speculum is still used during gynecological exams. By utilizing the bodies of Black women, doctors advance their understanding of how to remove burst ovaries, deliver stillborn children, stop intrauterine bleeding, fix fused labias, repair obstetrical fistula, remove ovarian tumors. The first full uterine removal was done by Dr. Paul Eve on an enslaved woman. Cesarean sections, 30 of 37 experimental cesarean sections were performed on Black women in 1830. But it wasn't just medical experimentation on the living. Enslaved people's dead bodies were dissected for the benefit of medical science. This is an image of human remains that were found in a well at Virginia Commonwealth University. And in 2019, the remains were formally memorialized. Human remains of African Americans have been found at numerous medical school sites throughout this country. Advertisements like this appeared in newspapers. No place in the United States offers as great opportunities for the acquisition of anatomical knowledge, subjects being obtained from among the colored population in sufficient numbers for every purpose, and proper dissections carried on without offending any individuals in the community. Enslaved people's bodies became part of a lucrative cadaver trade that shuttled Black people's bodies from Texas to New Hampshire. Upon death, Black people's bodies were still worth money. Death did not end their commodification. And I want to show now some of the images of these dissections. They are difficult to look at, so please avert your eyes as necessary. After slavery, in the 100 years between 1865 and 1965, the relationship between Black people and American healthcare remained as fraught as ever. Black people went from being valuable human commodities to being a problem that needed to be controlled and brutalized to be kept in their place. Through the 1960s, segregation infected all aspects of the US healthcare system, whether by law or by custom, throughout the country. Now, this was also the rise of African-American healthcare professionals, the formation of Black hospitals and Black medical schools. But the numbers weren't sufficient to serve the millions of Black people who had no access to medical care. Deaths occurred because Black people couldn't get to a hospital or doctor who would treat them. They were turned away when in serious need because Blacks were not allowed. When allowed into white hospitals, Black people were put into waiting rooms that were little more than broom closets with a few chairs. Hospital wards for Black people were often in dingy basements and back rooms. Black people received substandard care in segregated hospitals. My late father-in-law practiced medicine in Cleveland, and he saw all of his patients at their homes. They wouldn't go to the hospital because they were treated terribly there. You went to the hospital if you wanted to die. The 20th century also brought us more egregious medical practices that were waged against Black people. For most of the 20th century and continuing in different forms still today, state-sanctioned forced sterilizations were performed disproportionately on Black women, often without their knowledge or consent. Fannie Lou Hamer, the famous civil rights activist, went to a hospital in Sunflower County, Mississippi, to have fibroids removed, and she was given a hysterectomy without her knowledge or consent. Forced sterilization was such a common experience for Black women in the South that Hamer called it the Mississippi Appendectomy. And the famous Tuskegee syphilis experiment occurred between 1932 and 1972. It was the longest involuntary and non-therapeutic medical experiment conducted on human beings in the history of American medicine and public health. The US government performed this experiment on Black men in Macon County, Alabama. They lied to the men. They told the men that they were being treated for syphilis. But these were lies. The study was designed to observe untreated syphilis in Black men. They pretended to give the men medicine. What they gave them was little more than sugar pills and vitamin water. They withheld life-saving medicine so they could observe how the disease killed Black people. Now, syphilis kills you slowly and often with excruciating pain. We know that some of the men went blind, some went insane, some became paralyzed, some suffered complications from cardiovascular disease, some became horribly disfigured. This is Raymond Vodeler, the on-site director of the Tuskegee syphilis study. He later became the director of the CDC. He said, "It is my desire to keep the main purpose of the work from the Negroes in the county and to continue their interest in treatment." So this was a government program led by the future director of the CDC. The Medical Committee on Human Rights was the medical arm of the civil rights movement. Hospitals would eventually desegregate during the late 1960s. But this means that Black people have only had more equal access to healthcare over the past 50 years, at least in theory. But the legacies of this long history that I've just flown through so quickly remains with us today. We should heed the words of Martin Luther King Jr., who famously said, "Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane." I began this talk by sharing research with you about how racial bias functions in medicine today. Your fears are valid. Racial bias is real. The distrust you feel is well placed. This afternoon, I've also traced a history of medical harm, from the slave ships that carried Africans to the Americas for over 400 years, to medical experimentation and dissection during slavery, to segregated medicine that excluded Black people or offered substandard care, to forced sterilization and Tuskegee. And that is just touching the surface. This is a history of trauma and harm, and it's a history of violence. Being sick is one of the most intimate and vulnerable experiences in our lives. Yet in that space of profound vulnerability, as Black people, we have fear when we seek care. That fear also lives in our bodies. The racism that we wrestle with every day is a chronic stressor in our bodies, making us more susceptible to chronic diseases like heart disease and diabetes. Nancy Krieger, a social epidemiologist at Harvard, says, "Bodies tell stories about the conditions of our existence." Our bodies are telling a story of trauma and harm, of a society that makes human flourishing for Black people and other people of color seem almost impossible in so many ways. And yet, we endure. Despite the disproportionate deaths, the mourning and the grief, we endure. And we have endured for generations, through it all. And through it all, we have had to make difficult decisions in order to survive, in order to protect ourselves and our families and our communities the best way we could. Many of you now have another difficult decision to make, whether to take the vaccine. Our Black healthcare professionals are advising this. As you can tell from this talk, I am not here to chide you for your distrust or tell you to run out and get the vaccine. It's not my place. It's a deeply personal decision that should be discussed with your family and with your loved ones. In time, I believe that those in the healthcare system will slowly earn our trust in the years to come. The doctors, hospitals, medical schools, and public health professionals that I work with give me hope that this will be the case. The hundreds of students at Yale who flock to my courses give me hope that the ground may well be shifting. But that will be a long, slow process. In the meantime, I will close my talk by saying that I believe we must trust one another. We must trust one another knowing that each of us will make the decision that we feel is best for ourselves, for our families, and for our communities. Thank you so much for listening.
Thank you so much, Dr. Roberts, for your research and for that lecture. There's a space at the bottom of the page for Q&A. We will turn to those questions in just a moment. If you have questions that you would like to ask Dr. Roberts, please feel free to write them in the Q&A in that Q&A link at the bottom. There's a little box there, or place them in the chat. I'm aware of how troubled I am physically from exposure to the information and the images, and I just want to sit with that for a moment. One of the most helpful things that you've offered us is the validation of this concern or the distrust that many of us feel. There is just generally some concern that the medical field or medicine or doctors are just not on our side, and you don't know whether or not you can trust them. As you know, what I shared that with you just before we started. Just today at the doctor's office with my mother, her white doctor doubled the medication and refused to explain to me what the medication does, and how troubling that was. I mean, that's just in a brief description. As you know, I went into greater detail. We're looking for some help right now to respond to that, and there's just demanding that that I trust her without knowing, what's going on. And the other thing that your lecture offers for us is the recognition that trauma does things to the body, and increases the potential or the likelihood of illness over time, and within this demographic, within the community. So I want to sit with that for a moment. It's an important thing to recognize that anxiety, distrust is not misplaced. This is what one of a message that comes loud and clear. Now, once we acknowledge that, we also must acknowledge the need for medical science at the same time. We must acknowledge that there are advances that speak to conditions that we face. And like all other goods and services in society, race has played a factor in how they are distributed. While they are available at the same time as they are within our communities. Here in this Chicagoland area where I am, there are vaccines that have not been derived from torture, but they're in the hands of an institution that has a history of torture. What should we do? How do we speak to that dilemma? I mean, I had this argument with my 96-year-old aunt just recently, who's from Mississippi, who refuses to get the vaccine. But at age 96, she has a history of memory, and she won't go near it. And in her mind, I mean, I was telling her, you're in the age group that is the first among the people in society who are supposed to be getting this thing. And her response to me immediately was, they should not be experimenting on elderly people. She immediately went to medicine and experimentation from white people. But no, Auntie, they're not experimenting on elderly people. But I mean, this is what she knows. How to speak to that? How do we speak to that?
It is such a huge dilemma. And, there's a public health project, a community health project that I started in New Haven. And we have different conversations on health education topics that are of interest to the local community there. And one of the things that comes up over and over again, they want to know, how do we advocate for ourselves in these medical care settings? And one of my partners in this project, he's a physician, and he's given some guidance about how to ask questions, how to get more information, how to feel safer. But the problem is something that Dr. Williams, you mentioned when you were at the hospital today, that your questions might just be ignored. And you might be told by the doctor, I don't have time for this. Are you a doctor? Why are you questioning me? This kind of attitude. So in some ways, and it's a difficult thing to say, but in some ways it's the luck of the draw with the medical practitioners and healthcare providers that you have. Some of them are going to be more generous than others. Some of them are going to listen to you better than others. One of the things that happened to my family over last summer was that my mother was in the hospital and they said that she had pneumonia, but there was no sign of pneumonia, and they wanted to discharge her from the hospital. And we had to really fight to keep her in the hospital. And then when they eventually did proper testing, they realized that she was hypoxic. She was not getting enough oxygen. And so if they had sent her home, her oxygen levels were so low, she could have died. It's such a difficult dilemma to think about. As you were saying, Dr. Williams, medicine has improved. The distribution of those resources is often determined by race and class and these other neighborhoods, these other things. But what does it mean to put your hands in, entrust yourself to a doctor who is going to administer a vaccine? What does the vaccine mean? Well, we know from the Black healthcare professionals that the vaccine has been tested and they've put it through the ringer. The National Medical Association, which is an important institution for Black people in this country, it was formed in response to segregation that the American Medical Association had. So these were Black healthcare professionals started this organization, and they exist still today, and they work very hard to try to advocate on behalf of Black patients. And they have put it through the ringer. They've tested it, they've looked at the evidence, and they have said that it is safe, and they have given their stamp on it. You know, as a historian, I can't really, judge one way or the other, but at least a group like that can give us a certain amount of comfort when it comes specifically to thinking about the vaccine, as opposed to all of the other sort of medical interactions that we have to struggle with and advocate on our behalf.
You say the National Medical Association. I didn't know about that organization. I didn't know about it at all.
Yes.
That's very helpful to know.
Yeah.
This reminds me of another struggle, another debate in medicine, one that I touch on in my intro to ethics course at McCormick around, it's an unfortunate comparison, but it is one that comes to mind for me, physician-assisted dying, physician aid in dying, the dilemma there, that it begins, at least the argument, it begins with a patient demanding their voice be heard, okay, for the ability to be taken off the machine. Okay, then it turns towards a demand a secondary demand for patient autonomy. On another level, for the voice to be heard, this is really clunky right now. Pardon me. This is really coming off the top of my head. The third move is for patients to have their voices, actually their needs met. So it moves from a patient autonomy, a demand to have their voices heard, to be taken off the machine, to patients being neglected by doctors when medical insurance might be perceived as inadequate. This pendulum swing within medicine, in arguments within medicine here, perhaps can mirror something along the lines of this obsession with Black bodies in medical treatment, and now maybe even some might describe as a disregard of Black bodies and the lack of access to medical attention. So in the north part of the city, there have been descriptions of people with access to the vaccine because of money, because of zip code. You know, in other parts of the city, they're still languishing and waiting. Other Black parts of the city languishing with no access or different access. And I'm wondering if attention to that may also speak to the way that race in medicine is played out in society. So in addition to the legitimate cause for concern over whether or not they actually care, there's also this, you don't get access to this thing as well.
Yeah, absolutely. One of the things that I've been hearing in various circles is, you know, thinking about where hospitals and medical centers are located in relationship to where different vulnerable populations are located. And, you know, one of the things that I've heard people discuss is having doctors go to the people rather than having the people go to these medical centers, because the way that some cities are organized, and the way that some just rural areas are organized as well, it's very hard. It can, you know, for when you have limited funds and you're relying on public transportation, and if you have to take, you know, one bus and two trains, leaving off of work to try to get to a medical appointment, and then you're late, and then the doctor basically chastises you and makes you feel like you're, you know, a terrible parent for being so late bringing your child to an appointment, for example. I mean, it compounds all of these different struggles. So what you're pointing out is really important, because what we're talking about are the conditions on which people are living. You know, where do they have access to transport? Where do they have access to healthy food? Where's the vaccine located? I remember that when COVID first happened, they were talking about the testing sites. The testing sites were going to be in certain places, and they were drive-through sites. Well, what about the people who have no cars? How are they going to access these drive-through sites? You know, and so there are so many inequities that sort of are compounded, which I think gets at, you know, what you're observing, which is really important.
Thank you. I think we have a number of questions to address here. I think now we'll turn to them. Some of them may take some time to respond to. Let's begin with this one by an anonymous attendee. How do we learn to trust medicine and follow the science today when these practices and deaths are still happening? What recourse do families and individuals have when they experience medical malpractice? That sounds like it may be one for medical attorneys as well. But I think we're talking here more about the history of this trauma on the ongoing collective psyche of Black people.
Yeah, yeah. You know, we have to as a people in all of our different communities, we have to begin finding additional ways of healing. And I know that you, Dr. Williams, and this is being held at McCormick Theological Seminary. There's a really important role for faith-based communities and others to help people begin to reckon with the mistrust, the harm, the damage. We have to protect our nervous systems.
Mm-hmm.
Racism is a chronic stressor.
Mm-hmm.
It is sending us into fight or flight situation all the time. Black people don't sleep as deeply or as well as people of other races. It is happening throughout our bodies. So what are the different kinds of practices that we can develop that can help slow our nervous system down? Things like meditation and prayer and deep breathing and other things. We have to find ways of being able to heal. Now, there are going to continue to be deaths. That is the reality. People are going to keep dying. What can we do about it? Which is something I hear from this question. What can we do about this?
Mm-hmm. Mm-hmm.
We have to try to keep ourselves healthy in all of the different ways that we can. Not only, the things that are being told about social distancing and mask wearing, but the things that we know in terms of the sort of the texture of our lives. But then again, the question comes to me, and I'm not a public health expert. A public health expert would probably have a very eloquent sort of answer to this. But I say these things about, well, we need to we should try to have healthy practices. We should try to do these kinds of things. Well, what happens when you're not even near a grocery store that has adequate fresh vegetables and fruit? Why is it more expensive to buy water, to buy spring water at one of our neighborhoods here in New Haven that's predominantly Black, as opposed to buying that spring water at Whole Foods? Why is it more expensive? There are so many ways that it makes it so difficult for us to try to protect ourselves. And so, I guess, thinking about some of the food justice movements that are going on and things like this, people are trying. But it is a constant struggle. And we, within the resources that we have to find a way.
Mm-hmm. Thank you for that. Brianda Barrera says, I am a pharmacy technician, and currently the pharmacy that I work at is giving about 500 COVID vaccines a week. Yesterday at work, I was inputting demographics, and out of 150 patients that I was documenting demographics for, not one of them was Black. How much of this do you believe is from fear, and how much do you think is from lack of access? This is the question one of the questions that I was asking.
Yeah.
I was raising, and there is some hard data right there.
Yeah.
And I should add to this just one caveat, one comment. I have members from my church in courses with me right now, and I know that some members of the church, my church, Trinity United Church of Christ, on Chicago South Side, were vaccinated, and in the vaccine location was on Chicago South Side, primarily Black, and one of the members of the church that was vaccinated was surprised to see how many white people were present within the line, while the numbers of Black people were not representative of the community. I should say the number of people there in line, the demographic of people in line were not representative of the community. So there's clearly a disproportionate rate of access still being practiced. Yeah. Back to Brianda's question.
Yeah, absolutely. I've heard similar things coming out of Boston from people who have talked about that if they have a vaccination site in a predominantly Black neighborhood, all of the people, you know, the majority of people in the line to get the vaccination are white people, not members of the community. You know, it's the question of access versus, you know, distrust and people not wanting to get it probably is, you know, would be understood on a city by city kind of, you know, kind of schema, because where vaccines are, you know, where vaccines are located versus where people are probably varies. But in the case that you're describing, I mean, there's a lot of distrust. There's a lot of distrust coming through. And it's something that is not easily solved, as I, you know, was sort of showing in my talk. You know, trust has to be earned. And it would be difficult if you had, say, someone who was the victim of, you know, abuse or violence to say, oh, you know, the help that you need is back there in that space. Just, you know, walk in there and take it. It's a difficult situation to ask people that might have been traumatized by a healthcare system to go in it to get this help. And so it's the kind of situation that for me as you know, as a historian, I can't, you know, I know that the medical professionals and the National Medical Association and other people are saying, you know, you have to get it, you have to get it. It's really important to get it. You know, for me as a historian, I can't, you know, I really do think it's a personal decision, and it's should be a carefully considered decision. And dealing with that distrust. I gave a talk recently at Mount Sinai Morningside to their pulmonary and critical care division. It's a hospital system in New York City. And one of the surgeons was talking to me also about distrust. And we were talking about one of the things that studies show is that if you have Black healthcare providers, oftentimes it helps bridging these gaps of trust. It can really help. And he was saying that the problem is also that they don't have enough Black people in these roles to help to do this trust building exercise. And he's really, really concerned by the low number of people getting the vaccine. So I think that across the board, whether it's, you know, people in public health, whether it's, you know, doctors that are practicing, people like me who look at things through historical perspectives and link the past and the present, I think all of us are in some ways sort of scratching our heads. But the thing that I think is not a mystery, which is I think why history is so important, is that why are we scratching our heads? When you hear about the experiences that people have had, we actually, any reasonable, logical person would say, of course, there's got to be distrust. And so scratching our heads about the distrust sort of can make sense when we think about things in historical perspective, and thinking about Dr. Williams and his mother immediately saying, oh my gosh, you know, why are they experimenting on older people? Of course, that's going to be where your mind would go. So the problem isn't actually the fact that, you know, oh my gosh, there's distrust, what do we do? The question that I think we should be asking is, what can we do to earn that trust back? what can we do in the meantime while hospitals and medical schools and all of these different institutions are trying to enact certain changes over the long run? What can be done in the immediate present moment to say to people in Black communities across the country, you can trust us? How can that trust be earned? And I think that should really be, one of the most pressing questions that we ask.
I have, one of my former students had asked me to deliver a talk on racism at her medical school. She was an undergraduate student with me, and she wanted me to have a conversation, something along these lines, to people in school, training to be doctors, because there are some medical conditions that are racialized. We know hypertension, sickle cell anemia, even with black men, earlier prevalence of prostate cancers and so forth. And the doctors in their office, when the patient is there with them and they're going through what kind of procedures or things they need to be concerned about, have a difficult time bringing up race. How do we mention this to talk about what kind of treatments that you should be getting if the doctor is white and the patient is Black? They struggle with how to broach this. So one of the treatments, I should say, one of the responses that you give to the lack of Black medical care workers is important. It's vital. And ironically, I struggled with a response to that question. Also, how to deal with that particular dilemma. If we can't speak in a broad sense about the way race plays into the distribution of services, or even virtues like care and compassion in society, it makes it difficult, very difficult, to have that patient-doctor relationship in a mixed race situation. Yeah. There are a few more here. I want to name. I wonder if you're still there, First Lady of Trinity, Monica Moss, who makes a comment here and asks a question. It's something along the lines of one that we've addressed now. She says, "I'm not convinced the medical field will acknowledge and transform quickly enough to repair the damage bias and racism have caused for African Americans in an effort to take responsibility for our own health." And for African Americans, in an effort to take responsibility for our own health and medical care, what do you suggest we do proactively to care for ourselves within the medical field we currently have? I think we've touched on this a bit, especially that one about looking for Black doctors. But in the absence of Black doctors, like my mom's doctor's not Black. I pull her out of that medical office today. We're looking for something else. But I don't know. Any direct suggestions? You've talked about well-being in other ways.
Yeah, it's such a great question, because for the majority of time that Black people have been in the United States, since 1619, Black people have relied on one another for their health and thriving. And so, even in the early years of the 20th century, the rise of the Black Women's Club movement, part of their role was to mobilize around health education. And there was Negro Health Week that was started by African American people. It lasted for 50 years. And they had sanitation cleanups and talks on nutrition and on infant care and things like that. So, I've been reading more recently, about doctors who are themselves going into Black communities, Black doctors going into Black communities to talk with people, to reach out to them, to help them. you know, with their strained amounts of time and everything else, they're trying. So we also have a long history of community uplift and community care. And so
we have our Terry Mason. We have our Dr. Terry Mason.
Yeah.
Out here in Chicago. Just shout out Dr. Terry Mason.
Oh, you know, it's really exciting to think about what those possibilities might be in this moment. I know that there are Black meditation groups and Black self-care, holistic healing kinds of interventions. I know that there are, you know, different communities that are gathered around healthy food and urban gardening and some of these food justice issues. And, you know, I think that on the grassroots kind of work that we see cropping up, that's, you know, been going on now for a little while, reviving that spirit. I mean, the Black Panthers during the 1970s, their entire fight was against medical discrimination. They started, you know, clinics and things like that, and tested people for disease, and had healthy food programs, and provided the first free breakfast programs to kids in the United States. It was started by the Black Panthers. So we have that tradition, and getting like-minded people together around a problem to begin to think through what could be done. How can we mobilize our resources using the institutions that already exist in our communities as touchstones for this work? I think that there's a lot that can be done.
I think so too. I think that's so. You're more than a historian. That's a wonderful response. So I'm going to put a couple of questions here together. Reverend Rhonda Hoskins is asking, what types of organizations and colleges are you sharing this kind of information, and what have their responses been? Let's start. We can start there.
Yeah, you know, it's really interesting to me. Talks at hospitals, talks for medical institutions, talks also for, you know, like for PBS Nova, workshops that talk about race and science, and, you know, how do we tell these stories of race and science? PBS Nova is the oldest sort of scientific documentary series in the country. And so they want to figure out, how do we tell stories of medicine and race? So there, and then of course, universities, a lot of universities, a lot of medical schools. And I will say that across the board, 100%, every response to my talks has been overwhelmingly positive. And the reason why, I've been told, is because people who are working in these different fields, they know something is wrong, and they can't quite put their finger on what in the world is going on. And history offers a diagnostic to them. So this problem is so much older than you. It's so much larger than you. Your institution is part of this broader pattern, because, as we know, medicine and science are not somehow abstracted from the world that they exist in. Medicine and science are very much a part of the social, political, and cultural worlds in which we exist. There's no way to pull them apart. And so because of that, we're in a situation where race and racism have been built into them from the very beginning. You know, if American medicine grows and becomes scientific in a slave society, that has to have had some kind of effect. And then the knowledge is passed down and passed down and passed down. And so the kind of positive response that I get is one of the reasons why I do feel there is a certain amount of hope to be had. But this is going to be slow changes. I'm not overly optimistic in terms of time. But one of the things that I say to the students that I teach is, it doesn't need to happen in my lifetime. If you all can go out and do this work so that by the time you're teaching medical school students, and you're, I'm talking about my undergraduates, maybe they're 18, 19 years old. By the time they're in positions of authority at medical institutions, and they have all this knowledge, maybe they will be able to also help change things. So the positive responses, I think, are promising.
Wonderful, wonderful. And it's not going to change by just ignoring it either. It's definitely not going to change by ignoring it. You can't say that the trauma is not trauma, right, or that the trauma shouldn't be trauma. This very blatant, very intentional look at the reality of it is important towards healing, towards, to use a medical term here, an accurate diagnosis. Last question here. Why don't we wrap up here with Anita Crittenden, who asks, I've heard Black medical students speak to how much racism is in medical schools also. Can you speak to the Black Tulane University medical students? Are you familiar with this? Just to be sure, she says that Black Tulane University medical students recently posed at a plantation. And I'm not familiar with what she's referring to here. How far could this speak to how far we've come, how far we need to go? Does that ring a bell at all? I'm not sure.
It doesn't ring a bell, but I can speak to the experiences of Black medical school students and residents.
Okay.
They come to me in tears because of the things that they experience. I had an experience speaking to psychiatry residents. And when they do their, shadow the professors when they're doing their rounds, and every day they have to ask themselves, when they see racist behavior coming from their professors who are working in hospital settings towards Black patients, every day they have to ask themselves, is today the day that I say something? Is today the day that I potentially risk losing my career because I'm challenging this powerful, important person? They are themselves traumatized. The first talk that I gave to a medical school was at Yale. And I had students that came up to me afterwards, and they said that the history that I described, they feel like they are living in the aftermath of this history. Whenever they are in the hospital and they see how their attending professors treat Black patients. When they see their professors treating Black patients, they feel this history, the weight of this history, because of how racist the practices are. They hear people joking, even in the rooms where they are in the rooms where the residents and doctors are, joking about Black patients, laughing about them, calling them names, doing all of this sort of behind closed doors. There's a huge problem. We need to support these medical school students because their numbers are so low. And so there are a lot of different initiatives happening at various medical schools. It is not an easy journey for them. And in some ways, they are going to be more martyrs to this cause for change, because they're going to have to go through things that are reprehensible and stick with it so that they can get to the other side and try to make change themselves. But the cost on them is huge. It's absolutely huge.
Yeah. Well, and for those of us who don't have the experience of the student nor of the person in power to change something, like I mean, being a doctor or somebody working within the medical field, but somebody who's relying on them as a Black person, we find ourselves needing to figure out how to navigate these spaces, and the validation of the trauma is important. So spending this time to have this conversation is vital to acknowledge the reality of this. When I teach about racism in mixed classroom, mixed company, mixed race company, I often say this: there are two questions that I get very early on. And it's interesting how racialized they are. Interesting is not the right word. It's just kind of, I've noticed this. Okay, I'm going to get a question that says, what does this mean? What does this mean for us? That usually comes from Black students of color. What does this mean? They're trying to interpret, like me in the doctor's office today with my mother, trying to interpret this doctor saying, I don't have time for this question. Or tossing me 39 pages of something to read instead of answering my question and doing it disrespectful. What does this mean? But then the other question is, what do we do about it? Yes. And that question often comes very early. It comes too early. It seems to me that to understand what we're facing is also to see a bit of the solution. No compassion, the lack of care, lack of distribution of resources here. These are all constituents of the harmful ideology of human difference that still lingers with us today in what scholars have described as slavery's afterlives. The wake of the ship that passes through the water, the terrain after the big catastrophic event, the wake, the ritual after the death before the funeral, the wake, and we are in slavery's wake. The ideology that made that a logical thing to do in the world is still with us, and to discern that is to speak to what we should do. But your research is so important for us to recognize how pervasive it is. It goes without saying. We saw, 4 years build the wall type stuff, but you showed pictures of dissected bodies with language like "his loss, our gain," lived for others, died for us. You know what that brings to mind for me, and I didn't mean to do this tirade at the end, this long thing at the end, but it brings to mind to me something what the father of Black theology, James Cone, would say. He'd say, in a nation that is Christian, the representative of Christianity, the real representative of Christianity in the country is not Jesus on a cross outside of the walls of Jerusalem, 2,000 years ago, but Black people on crosses all over the country in an effort to purify white space of its biological contaminants. So there's something of a twisted joy also in that suffering for Black people. And to help Black people recognize that what this means for us is the work of loving yourself first. Love yourself, love your community, and let's start from there. And in this moment with the vaccine, loving ourselves and loving our bodies may mean something, of discernment,
Yes.
some practice of discernment.
Yes, yes, I agree. Love, and being love with one another. We must be better with one another and with ourselves, pouring that love inward and sending it outward. We can build stronger communities by doing that. And there's people have rallied in incredible ways during this crisis. In Black communities all across the country, seeing the way people brought groceries and helping elderly people who couldn't get out of their homes. I mean, all of these things are there, and we just have to keep on doing those things. It might be that we need to have a group of people who are trained as patient advocates, and that maybe there's a program that can happen in one of the community centers or churches, teach people how to be patient advocates, so that when vulnerable people go to the go for their hospital or medical visits, there's someone there with them who can try to fight for them, the way that Reggie, you did for your mom. What does it mean? It means that we are still living in the United States of America.
Yes, it does.
And that we have survived, and we are going to keep surviving. But we can't lose sight of the fact that it has taken enormous amounts of ingenuity and creativity, passion and love and power. That Provident Hospital, built in Chicago, that money was raised by women who were domestics, who were putting in 10 cents, 20 cents. They built that hospital. They put in their pennies to build that hospital. That's the story of who we are and what we've been able to achieve. Can you imagine building a hospital in that way? But they did it. They did it. And we have to hold on to all of the good of this history, which I didn't have time in the 30 minutes that I was trying to stick to. I didn't have time to get into, but there are medicinal plants named after enslaved people because they knew how to heal. We have so much healing work, public health work, community organizing work throughout this entire period of time. So there is another story of medical resistance and health activism that is maybe another talk, maybe another story, maybe another trajectory that we can collectively spend time thinking about, because it's invaluable. We have the wisdom and the knowledge to do this and to thrive.
Well, if you're willing, we would love to have that another story from you here with us at McCormick. We are so grateful for this time that we've had together with you. You are brilliant, and the book for everyone who was here is be on the lookout for To Heal and to Harm, Medicine, Knowledge, and Power in the Atlantic Slave Trade by Harvard University Press. When that is available, we will make sure that everybody knows about it here from our community. Dr. Roberts, I would be remiss also if I did not tell you that my daughter says hello. Simone is watching. I think she might still be here. She says hello.
Oh, wonderful. Hello, Simone. It's wonderful to know that you're there.
Thank you so very much. Thank you so much. Hey, there she is in the chat.
You're so very welcome. It was such a pleasure. And I wish everyone health and safety and wholeness.
Okay. God be with you.
And with you. Bye-bye.
Bye-bye.